Good afternoon, everybody. It's 1 o'clock. Let's begin, and welcome to the CDC Public Health Grand Rounds. And today, we are talking about salt, or as our speakers are going to educate it, sodium in particular. Now, as you will see and hear, it seems that we are drenched in salt no matter how you take it, but I also wanted you to know that it's not that easy for the salt itself. It also has its own challenges in its life, as you can see from this particular slide. So we have to have some sympathy for both sides and have a fair and balanced presentation here. For those of you who are watching us at our IPTV or intranet, this is the web page that has been redesigned recently, where you can find all the information about the Grand Rounds, where you can receive email updates. You can even use it as your screen and homepage. For those of you who are joining us from outside, and that is usually the vast majority of people, upwards of 10 to 12,000 each time, this is our external internet site on which you can find all the archived sessions and all the detailed information about each one of our 19 sessions that we have had so far. We continue to coordinate these sessions with our science clips, and this time the selection was made by one of our speakers, to whom we thank for that effort. We are very fortunate to continue to be getting a lot of interest and a lot of viewership for our Grand Rounds, and so far over 200,000 people have actually watched the Grand Rounds, mainly through internet, but also in the past few months we have started using the YouTube as well, and there is a lot of interest in not as much as some of the stupid things, how many times you can hit the ball or whatever, some dancing, but still, given that this is science, I would say still a lot. This time, one of the things that I wanted to say, we have had some really cool and really lovely people on the past 18 sessions, but this is probably the best looking and on average youngest bunch of people. And even my assistant, who worked over the phone with me and talked to all of them, when they showed up in person, she came and said, "Oh my God, they're so good looking." And I said, "Hey, what can I say?" Some of them are our own CDC people, some of them come from FDA, and then some from New York City. I know that we may be abusing New York City a little bit, and I have no idea why we may have this specific affiliation with that city, but we do. As you know, the preparations for this event are intense, and each time we choose a specific sport. This time it was doubles tennis, and you can see Christine here giving the final hit as she will be doing it in our session today. Now, we work practically day and night to make this interesting to people, and pay attention. This is today, 11:35 a.m., a picture taken in my office of our FDA colleague, Jeremiah Fasano, who wanted to change just a couple of small things to make sure that his talk is perfect. And I wanted to end this by saying that every session has its angel guardian, and in this case, it was Nicole Blair, who managed to pull the rabbit out of the hat many, many, many times, and who has really been instrumental in coordinating with so many colleagues and so many of us who contribute in some way, and I really wanted to thank her and recognize her for that contribution. So as always, before our speakers begin, we will have brief comments by our director, who is not here with us today, but has taped his comments.
Welcome to Public Health Grand Rounds. Cardiovascular disease is the leading cause of death in the United States. Nearly 70 million U.S. adults, including more than 2/3 of people over age 65, have high blood pressure, the leading risk factor for cardiovascular disease. In 2010 alone, we spent about $70 billion in direct medical costs on hypertension and the diseases it causes. Despite this, our system fails to help more than half of people with hypertension to control it. It's estimated that excess sodium consumption accounts for up to 1/3 of all cases of hypertension, and almost everyone in the United States consumes too much salt. Sodium reduction is a top priority to prevent heart disease and stroke both in this country and around the world. In the United States, only about 1/10 of the sodium we consume is added in the kitchen or at the table, with most sodium coming from processed and restaurant foods, taking the choice of how much sodium to consume literally out of the hands of individuals. Setting targets to reduce sodium in specific processed foods can result in substantial reductions in sodium intake on the population level. Reducing sodium intake to recommended levels could save more than 100,000 lives and billions of dollars in medical costs. This session of Public Health Grand Rounds will explore the health burden of excess sodium and strategies to reduce sodium intake. Reducing sodium intake will require involvement of the food industry, policy interventions, and rigorous monitoring. If, working together, government and industry can achieve substantial reductions in sodium intake, we will truly have shown that we're worth our salt.
Good afternoon, and thank you, Dr. Popovich and Dr. Frieden. I'm Darwin Labarth. I will explain this afternoon why excess sodium is a significant health problem, the cause and effect relationship of sodium intake and blood pressure, the benefit of reducing sodium in the food supply and restoring choice, and some of the myths and misconceptions about sodium. Sodium chloride is the chemical name for dietary salt. It contains 40% sodium and 60% chloride. Nearly all of the sodium Americans consume is in salt from our food. The vast majority is already in our prepared, processed, and restaurant foods. The words salt and sodium are often used interchangeably, but they are not the same. The one to watch is sodium on the nutrition facts label of packaged foods. Excess sodium causes hypertension. Nearly 1 in 3 U.S. adults, 68 million people, have hypertension. Of those who reach middle age, 9 in 10 will develop it by the time they reach older age. More than 1 in 2 people with hypertension, 34 million American adults, do not have it under control. With the further addition of people with pre-hypertension, those with blood pressure elevated above normal but not enough for medical intervention, reducing sodium intake can have a major public health impact. Sodium through hypertension is a major contributor to death, disability, disparities, and costs attributable to cardiovascular diseases or CVDs. CVDs are leading causes of death, killing some 800,000 adults every year. CVDs are also leading causes of health disparities by race and ethnicity. Treatment of CVDs accounts for 1 in every 6 U.S. health dollars spent, or about $273 billion every year. In 23 developing countries, more than 8 million deaths could be averted over 10 years if average sodium intake were reduced by just 15%. The body only requires about 230 milligrams of sodium per day. A healthy diet contains no more than 1,500 milligrams sodium per day at any age. In fact, only 1,000 milligrams per day for children. That's the adequate intake, or AI. The 2010 Dietary Guidelines for Americans recommend 1,500 milligrams per day for people age 51 and older, African Americans, and those who have high blood pressure, diabetes, or chronic kidney disease. That is virtually half the U.S. population, and the majority of adults 18 years and older. All others should reduce sodium intake to less than 2,300 milligrams per day. But the current sodium intake of U.S. adults is more than 3,400 milligrams per day. There is a solution. Solid scientific evidence shows a direct causal relationship between sodium intake and blood pressure levels. When people reduce their sodium intake, their blood pressure decreases, and almost everyone benefits from lowering their blood pressure. For example, in middle-aged men, decreasing population systolic blood pressure by just 5 millimeters mercury can lead to a 1 in 7 reduction in stroke deaths and 1 in 11 reduction in coronary heart disease deaths. Reducing sodium intake is a key public health strategy to prevent and control high blood pressure. Decreasing average population intake to 1,500 milligrams per day could result in 16 million fewer cases of high blood pressure and an estimated saving of $26 billion every year. Even if average intake were only reduced to 2,300 milligrams per day, we could still expect to see a decrease of 11 million cases of high blood pressure and a cost savings of $18 billion in healthcare expenditures, again, every year. Nearly 80% of the sodium in our food is already there and mostly invisible. It comes from foods we buy in stores and restaurants. Only 12% is naturally occurring in fruits and vegetables and whole grains. And about 11% is added in cooking and at the table. More recent unpublished data support this same estimate. So it is not just the salt shaker. Given our current food supply, it's extremely difficult for people to reduce their sodium intake. Finding low sodium or no sodium added options in the grocery store can be difficult. Identifying low sodium restaurant fare can be an even greater challenge. And once sodium has been added to your food, you can't take it out. Reducing the sodium content of restaurant and processed foods is a key approach to reducing sodium intake. The food supply must change, even if gradually, to enable choice and support our national dietary goals. Other approaches include more information for consumers at the point of purchase, both on food labels and on restaurant menus. The food industry can help, and there are signs of change. You'll hear more about some innovative programs from Christine Johnson in just a few minutes. Let me dispel some of the myths and misconceptions that have contributed to delays in reducing sodium intake. First, there's not enough evidence to act. A very large body of strong scientific evidence shows that increasing sodium intake increases blood pressure and reducing sodium intake reduces blood pressure. And moreover, current sodium intake far exceeds safe and healthy levels. Recent examples of the numerous bodies that have supported sodium reduction beginning 40 years ago are listed in this slide. Second, population sodium reduction is a risky experiment. The experiment with sodium has been its increase in our food supply, coinciding with our increased reliance on foods prepared for us rather than by us, either packaged for retail purchase or in restaurants. Reducing sodium intake has been shown to be safe and effective. Third, sodium reduction is only important for people with high blood pressure. On the contrary, the recommended levels of sodium intake are important for everyone. Lower sodium intake helps prevent high blood pressure in the first place and helps control high blood pressure when it is high. Both hypertension and prehypertension can be prevented by reducing sodium intake. The risk of having a heart attack or stroke goes down when blood pressure decreases. This reduction in risk continues even below the range of what is considered normal blood pressure. There is no basis to recommend sodium consumption that exceeds the adequate intake level. Fourth, there's no justification for government action. Quite the opposite. There is need and justification for government action. Voluntary action by the food industry has been inadequate despite 40 years of calls to action. Consumers deserve more choices and more control of the sodium levels in the foods they eat. Government can promote or require changes in sodium content of foods through food procurement policies, public information, industry regulation, and other strategies, all coupled with monitoring and surveillance. One example is the General Services Administration, Department of Health and Human Services, Health and Sustainability Guidelines for Federal Concessions and Vending Operations, released last month, which set standards for foods contracted through GSA and served at HHS facilities, including CDC. And government must share its role with industry, policymakers, media, and the public at large. Finally, food will lose its taste. In reality, excess salt masks other flavors, so we lose the real flavor of foods. The appeal of salty tastes comes from becoming accustomed to unhealthy, unsafe salt intake. It's easily reversed, especially with gradual changes. with less sodium in our food, we can appreciate again the wide variety of natural flavors. So taste the tomato. Excess sodium intake is taking a toll on the health of the population. Most of us exceed our recommended daily levels of sodium intake. Once salt is added to your foods, you can't take it out. Changes in food processing and preparation can bring choice and control back to the consumer. We believe government has a clear role to improve the food supply by working with diverse partners to increase access to healthier food options. Our subsequent speakers will address some of these issues in more detail. Dr. Fasano will focus on food technology issues related to sodium in our foods. Dr. Cogswell will talk about monitoring sodium levels in both the food supply and the population. And Ms. Johnson will discuss the National Salt Reduction Initiative and other efforts to support sodium reduction at the state and local level. Dr. Fasano.
I'm Jeremiah Fasano. I'm pleased to be here to participate in this event. Dr. Labarth has already mentioned the serious public health concerns that are associated with excess sodium intake. FDA fully supports these concerns. Today, I'm going to provide a little bit of technological context for the widespread use of salt in food and what substances can potentially be used to replace salt. I'll also speak a bit about past and current activities at FDA relating to the use of sodium in food and efforts to reduce sodium intake, as well as the recommendations of the Institute of Medicine regarding sodium reduction. There are three primary reasons that sodium chloride, or salt, is used in food. The first, for flavor. The second, for safety. Microorganisms generally don't grow well in salty conditions. And third, for food processing. Salt can change the properties of other food components in ways that are useful to food manufacturers. Salt's unusual in that it often serves more than one function in the food at the same time. Now I'll talk about these factors in more detail. Salt's one of the 5 primary tastes: sweet, salty, sour, bitter, and umami. The sodium ion is the substance that's actually responsible for the perception of saltiness. Recent research suggests that our perception of salt taste depends on a dedicated taste cell that responds only to the sodium ion. There appears to be a second cell type that's activated at higher concentrations by a number of similar ions, such as potassium and calcium. This point will become relevant later when we discuss salt substitutes. Salt taste also alters our perception of other tastes. Most notably, salt taste can mask bitterness in a food and can also enhance the apparent sweetness of the food. Salt's the oldest food preservative. The primary reason it's so effective is that it keeps water in the food locked up so that it's not available for microorganisms. Without sufficient water, most microorganisms can't grow well. If the salt concentration is high enough, it can actually kill microorganisms outright through hyperosmotic shock. Salt can also interfere with the activity of enzymes that microorganisms use to break down the foods they're growing on. And finally, it's worth noting that sodium is a component of many other commonly used preservatives such as trisodium phosphate and sodium lactate. Salt also aids in the processing of foods in a number of ways. For example, it can tenderize protein-rich foods such as meat by causing proteins to separate from one another. Paradoxically, it can also cause proteins to lose their native conformation and stick together, which helps some foods hold their shape. Salt concentrations can regulate the growth and activity of bacteria and enzymes used in food manufacture. For example, cheesemaking includes a ripening step that imparts flavor and character to the finished product. It's caused by bacteria and enzymes present in the food. Salt's a key control point in this step. Finally, salt's helpful for retaining moisture and altering texture in a food. Let me illustrate these roles I've just discussed with a few examples. In bread, the most important effects involve strengthening of the gluten net that allows rising and influences texture, and salt also affects the activity of yeast in yeast breads. Cheesemaking involves the activity of both isolated enzymes and often entire microbes, both of which are influenced by salt, as I've already alluded to. Changes in milk protein properties are also important. Salt's an essential regulator of cheese structure and ripening and draws the moisture out of the curd. In meats, salt's a long-standing preservative. In addition, ground meat products such as sausages tend to disintegrate when the salt concentration is too low because of the effects of salt on protein aggregation. Finally, flavored snacks often use salt as a vehicle for other added flavorings. Replacements are available for various salt functions, although in general, no one substance can completely replace salt. Here are some ingredients that have been used as sodium substitutes. Other salts can be used as direct replacements for some of the sodium chloride added to a food. Most commonly used replacement today is potassium chloride. Calcium and magnesium chlorides are also used. They all tend to have a bitter taste in excess and are often mixed with sodium for this reason. Reduced sodium sea salts are also used for this purpose. On a historical note, lithium chloride is actually the salt most similar to sodium chloride, and unlike others, can fully activate the sodium taste cell. Unfortunately, it turned out to be toxic, and its use was abandoned after about 1940. In some cases, other substances can amplify existing flavors or substitute a similar overall taste. However, it can be difficult to maintain a similar food flavor profile. Finally, antimicrobial functions of salt can be taken over by a variety of ingredients, such as lactate salts, bacteriophages. However, the need to maintain food safety means you have to do extensive validation for every use scenario. A variety of new technologies are being developed that may be useful for sodium replacement. For example, some firms are developing microcapsules of potassium chloride that contain a debittering agent. Another product that's beginning to enter commerce is a hollow microsphere of sodium that imparts a similar taste experience at a lower absolute salt concentration. Finally, some firms are experimenting with ingredients that directly manipulate the properties of the ion channels in the taste receptor cells to amplify, for example, the sensory signal of a given absolute amount of sodium chloride. However, the cost impact of both currently available substitutes and new technologies remains an issue. For some novel substitutes, availability of appropriate safety data may also be an issue. FDA is engaged in various efforts over the past few decades aimed at promoting awareness of sodium content and encouraging reduced sodium intake. These efforts include sodium content labeling on packaging as early as 1984 and promulgation of standards for sodium content claims. FDA also arranged a public hearing in 2007 to solicit information on ways to reduce sodium intake. Finally, recent work on front-to-pack labeling and the upcoming mandatory menu labeling mandated by the Patient Protection and Affordable Care Act may also increase consumer awareness of sodium intake. In 2010, the Institute of Medicine issued a report entitled Strategies to Reduce Sodium Intake in the United States. In this report, they concluded that labeling and education efforts in isolation had not significantly reduced sodium consumption in the U.S. The Institute of Medicine had a number of recommendations. The primary recommendation was to pursue broad, gradual reductions in sodium content of both packaged and prepared foods in the United States. The Institute of Medicine recommended the promotion of voluntary initiatives as an initial step, involving collaboration of industry, government, and other stakeholders, as well as the initiation of a process to set mandatory standards. The Institute of Medicine also recommended revisions and extensions to current labeling of food to support sodium reduction efforts. Finally, the Institute of Medicine recommended efforts to monitor changes in sodium intake and salt taste preference in the U.S. population, as well as changes in the sodium content of food over time. At this time, FDA is carefully considering all the recommendations provided by the Institute of Medicine. Thank you. Our next speaker, Dr. Mary Cogswell.
Thanks, Sharon. I'm Mary Cogswell from CDC. Oops, wait a minute. There. I will describe CDC's efforts to address three questions. How much sodium is in the foods we eat? How much sodium do we consume? And are we ready for nationwide action to reduce sodium intake? CDC's data on sodium in food and people comes from multiple sources. Sources primarily focused on sodium in foods are circled in blue, on sodium intake and excretion are circled in red, and on consumer and healthcare provider knowledge, attitudes, and practices are circled in green. Today, I will focus on the latest data from USDA's food and nutrient databases, the National Health and Nutrition Examination Survey, the Behavioral Risk Factor Surveillance System, and 2 market research surveys. As part of a collaboration with the USDA, CDC updated sodium values of foods that are major contributors to the U.S. diet. They reviewed approximately 1,300 mainly processed foods and updated 450 due to a difference with previously published values. These new values are included in the 2010 National Nutrient Database, which provides the foundation for most U.S. private and public food composition databases, including that used with NHANES. USDA is also conducting laboratory analysis of sentinel foods that contribute high proportions of added sodium to the U.S. diet. One finding is that mean sodium values can vary up to 10-fold for different brands of the same food, showing that sodium decreases in the food supply are possible even now. Laboratory analysis for sodium are essential, as the label only has to be within 20% of the actual value. Differences in actual and labeled sodium values are shown here for 3 brands of pasta sauce that were analyzed in 1999 and 2009. As it should be, for brand A, actual and labeled values decreased about the same amount. For brand B, actual values did not change, but labeled values decreased 24%. And for brand C, actual values decreased, but labeled values did not change. Therefore, relying on labeled sodium values could result in wrong conclusions about changes in the food supply of sodium over time. Now focusing on sodium intake. In 2003 through 2008, the vast majority of U.S. adults, which means all of you in this room as well almost, consumed more sodium than recommended, regardless of recommended level, age, sex, or race ethnic group, suggesting the need for widespread population interventions. Even among women who consume the least amount of sodium, over 98% consumed more than 1,500 milligrams per day, and more than 75% consumed more than 2,300 milligrams per day. I'll now focus on readiness to reduce sodium intake. In 2007, regardless of age, over 50% of adults with self-reported hypertension reporting being advised to reduce their salt intake, and among those advised, the vast majority reported that they were currently reducing their salt intake. The next 4 slides show 2010 data on consumer readiness to reduce sodium from a national market panel survey of 10,000 U.S. consumers. As shown here, regardless of age or race ethnic group, the majority of U.S. consumers either moderately or strongly disagreed with the statement, "Salt really isn't that bad for you," suggesting that consumers understand the relationship of sodium intake and health. When asked, thinking about your salt intake, which of the following best describes you? As shown on the left, the majority of consumers aged 18 to 50 years reported either thinking about lowering their salt intake or having taken action, that is, taking steps to lower their salt intake or having already lowered their salt intake. As shown on the right, a greater percentage of older consumers, 68%, reported either thinking about or having taken action to lower their salt intake. Unfortunately, given the state of the food supply today, it's almost impossible for individuals to lower their own sodium intake, or make a big difference, actually. Regardless of age, sex, or race, ethnicity, the majority of U.S. consumers agreed with the statement, "I think it's a good idea for government to keep food manufacturers from putting too much salt in food." The greatest support came from Black consumers. Among almost 70% agreed. A slightly lower percentage of consumers agreed with government regulation of too much salt in restaurant foods, with the strongest support from Black consumers. Transitioning to healthcare providers, this slide shows 2010 data from a web-based survey of family practitioners, internists, and nurse practitioners. Regardless of specialty, over 80% agreed most of my patients should reduce their sodium intake. In summary, the vast majority of U.S. adults consume excess sodium, reinforcing the need for widespread population interventions. Laboratory analysis of sodium in foods is essential for accurate monitoring of reductions in sodium intake, and consumers and healthcare providers seem ready for reduction of sodium in food. In particular, the majority of consumers agree with government regulation of too much salt in manufactured foods, and greater than 40% agree with regulation of too much salt in restaurant foods. Future actions include completion and implementation of the USDA, CDC, FDA Sentinel Sodium Food Monitoring System to allow early detection of nutrient changes in the U.S. food supply. Determining and implementing the optimal method for population monitoring of U.S. sodium intake through biological markers. And finally, continued monitoring of consumer readiness and acceptance is essential if we are to eliminate excess sodium and to decrease hypertension, heart disease, and stroke. Our next speaker is Christine Johnson.
Good afternoon. I'm Christine Johnson from the New York City Department of Health and Mental Hygiene. I'll talk about three major efforts to reduce sodium content of foods that intersect and work synergistically in New York City: the National Salt Reduction Initiative, New York City's sodium reduction activities, and the Sodium Reduction in Communities grant. The National Salt Reduction Initiative, or NSRI, is a national initiative with the overall goal of reducing population sodium intake by 20% in 5 years by decreasing the sodium in packaged and restaurant foods by 25% over the next 5 years. This is consistent with calls from the American Medical Association and the American Public Health Association for a 50% reduction in the salt content of packaged and restaurant foods within 10 years. We chose a shorter time frame in order to focus discussions with industry and to allow for the assessment of industry progress. New York City held preliminary discussions with industry about reducing sodium. While they expressed support, they noticed their interest in a national approach. In response, the NSRI was launched in October 2008 by the New York City Health Department, which coordinates the initiative. This partnership has grown to over 70 health organizations and health departments, including 29 states, 15 cities, and 28 national organizations, such as the American Heart Association. Partners sign on to a statement committing to reducing population salt intake by at least 20% over 5 years by setting targets and monitoring industry progress through a transparent, voluntary, public process. The NSRI strategy is modeled on the UK's evidence-based model for sodium reduction, which includes setting sodium targets, working with industry to confirm commitments, and monitoring progress over time. The NSRI created national nutrition databases for packaged and restaurant food to inform the development of the food categories and the sodium content targets, which were refined based on industry feedback. We have two mechanisms for monitoring industry progress. The first are the national nutrition databases, which allow us to assess detailed information about each category in 2012 and 2014. In addition, we ask for company-submitted reporting forms on the relevant food categories. Finally, we've developed a separate evaluation to assess changes in sodium intake in the New York City population. The NSRI databases for packaged and restaurant food were created based on publicly available nutrition information and proprietary sales data. The packaged food databases merges both sets of data, which allows us to assess the mean and range of sodium content by category, brand, and product type, which informed how we defined food categories and set the targets. Additional details are provided here and in the IOM report on strategies to reduce sodium. Based on the database analysis, the NSRI developed voluntary targets for 2012 and for 2014 for 62 packaged food categories and 25 restaurant food categories. Types of packaged food categories include bread and rolls, crackers, processed cheese, canned beans, and restaurant food category examples include hamburgers with cheese, sandwiches with luncheon meat, soup, and pizza. Discussions on these targets occurred with a wide range of packaged and restaurant food companies at the table, including private label companies, food distributors, trade associations, and food service companies. Companies also had an opportunity to participate in category-level meetings, individual meetings, and to submit written comments. The targets were proposed based on analyzing the NSRI databases and assessing technical feasibility, and then were refined based on company comments and ongoing discussions with the industry. We talk about using the sales-weighted mean for the NSRI targets, which means that the content of more popular products influences the mean more than the sodium content of products with lower sales. As an example, let's look at the bread and rolls category. Companies can commit to a 2012 target of 440 milligrams of sodium per 100 grams of food. To meet this target, the mean sodium content of all of a company's products in this category, weighted by their sales, must be at or below the target by January 2012. Although there may still be some products that are above the specified target, what's important here is the average. Restaurant targets work in a similar way. Since we announced the NSRI targets in April 2010, 28 companies have signed on to NSRI targets, including 19 major packaged food companies, 4 supermarkets and food distributors, and 5 restaurant chains listed here. Companies have received ongoing press attention because of their involvement in the NSRI, particularly around the 3 press announcements, and have capitalized on it in their own advertising and their press releases. The NSRI is different from past calls for voluntary industry reductions because it provides a clear and transparent way to monitor changes in the food supply. We will recreate the packaged and restaurant food databases described earlier in both 2012 and 2014. This will allow us to track individual company and overall food industry progress for every category. In addition, we ask companies that have committed to NSRI targets to submit product-level data for each category they commit to. We're also evaluating the NSRI by measuring changes in the New York City sodium intake through the gold standard, 24-hour urine analysis. We conducted a baseline study in 2010 where we recruited participants from the New York City Community Health Survey, a telephone survey modeled on the BRFSS. The study was conducted with a representative sample of just under 1,800 New York City adults. Data collected included sodium, potassium, and creatinine, in addition to a number of other variables listed on the slide. Our results show that overall mean New York City adult intake was approximately 3,150 milligrams per day. Only 11% of high-risk New Yorkers whose recommended daily limit is 1,500 milligrams or below were at or below that level. Further, only 21% of all New Yorkers met their recommended limit, whether it was 1,500 or 2,300 milligrams per day. Results are weighted to be representative of New York City as a whole, and further analysis is underway. In terms of future plans, a follow-up will be conducted in 2014 to track changes in sodium intake. In addition to coordinating national action through the NSRI, New York City is working on sodium reduction locally. New York City is the first large city in the U.S. to set standards for all foods purchased and served by city agencies, which were officially put in place by mayoral executive order in 2008. The standards for meals and snacks purchased and served establish nutrition standards for all city agencies, which affect over 260 million meals and snacks served each year at schools, senior centers, daycares, homeless shelters, and other city programs. We also developed standards for beverage vending machines. Both sets of standards are available on the New York City Health Department website. Here are a few specific examples of sodium requirements for purchased food that are set by the standards for meals and snacks. Cereal must contain less than 215 milligrams of sodium per serving. Canned and frozen vegetables must contain less than 290 milligrams per serving or have no salt added. And portion-controlled items and other convenience foods must contain less than 480 milligrams per serving. As a note, the federal government recently released concession and vending standards. The nutrient standards outlined in the Health and Human Services policy mentioned by Dr. Labarth in his presentation apply to all food concession operations and vending machines managed by HHS and the General Services Administration. The HHS policy includes nutrient requirements related to specific food categories as well as meals served. In comparison, the New York City standards are focused on meals and snacks served by city agencies and also include nutrient standards for purchased food as well as for the overall meal. Both the HHS and the New York City vending standards require calorie labeling, restrict trans fat, and set limits on the number of high-calorie beverages, in addition to other requirements. In terms of the standards for beverage vending machines, apply to all machines contracted by the city. Standards have 5 criteria that must be met. In terms of product mix, 2 vending machine slots must stock water. High-calorie beverages are limited to 2 slots. Also, water must be placed in the area with the greatest selling potential, at eye level. High-calorie beverages must be placed in the area with the least selling potential. In terms of product size, all beverages except water are limited to 12 ounces or less, and water must be at least 12 ounces. Marketing on the outside of the machine must promote healthy lifestyles or healthy beverages, and all machines must post calories per container for each product. Although not required, we recommend agencies use pricing models as an incentive for people to purchase healthier beverages. We have conducted a baseline observational survey and are planning a follow-up survey this year. In September 2010, New York City was one of 5 cities and states awarded a 3-year Sodium Reduction in Communities grant from the CDC. This grant supports 3 separate activities. The first is an independent restaurant initiative. New York City has approximately 20,000 independent restaurants, which account for 90% of the city's restaurants. We plan to work closely with a select group of restaurants and suppliers to develop an approach for reducing sodium that's scalable and sustainable. Our activities will include education and outreach through mailings, a website, and a sodium module in New York City's food safety course. The second initiative is focused on hospital retail food standards, with a goal for New York City hospitals to provide access to healthier foods, including lower sodium options. We plan to develop standards which will allow us to build on our current work with New York City public hospitals and support us reaching out to New York City private hospitals. Finally, the third activity is a New York City media campaign focused on increasing consumer awareness of the hidden salt in processed foods and broadening awareness of the health impacts of a high-sodium diet. The first phase includes a print ad campaign in New York City subways, local newspapers, and online ads. This is one of 2 subway posters. The main tagline is, "Many foods pack a lot more salt than you think," with a consumer message to compare labels and choose less sodium. A health bulletin on salt that was part of the campaign is available by calling New York City's 311. The second phase of the media campaign will be developed this year and will launch in fall 2012. The first 2 conclusions on the slide you may have already picked up on, but they're worth repeating. Average daily sodium intake for U.S. adults is more than double what is recommended as a safe level. Changes in the food supply are needed to lower sodium intake to recommended levels. We've also heard today about how the NSRI is promising as a collaborative and voluntary process because it requires industry commitment and includes a mechanism for monitoring industry progress objectively. And finally, we see that government has a critical role to play at federal, state, and local levels. Thank you so much.
Well, thank you to Jeremiah, to Molly, and to Christine. We have an opportunity now for participation from our audience, and welcome comments or questions for the panel. We would ask that you keep your comments or questions brief and focused, that you identify yourself by name and your organization, and please feel free to pose questions for the panel. Please.
Leonard Orban, CDC. One hears that the Japanese consume a lot of salt but don't have as much problem with hypertension and cardiovascular disease. How would you respond to that statement?
There has been a very valuable historical experience in Japan, which from the late 50s had among the highest rates of stroke mortality of any country in the world. Sodium reduction has decreased very sharply in Japan, and corresponding reductions in stroke mortality. I think this is one of the leading examples of what can be achieved at a national level by systematic efforts to reduce sodium intake. Thanks for the question. Other comments? One question that I could mention just while others are thinking of points they'd like to raise. Christine referred to the experience of the New York Salt Reduction Initiative in setting a baseline for sodium excretion through use of 24-hour urine collection. There's been a lot of discussion of that strategy. We are discussing it with our colleagues in NCHS as to a possible addition to the National Health and Nutrition Examination Survey. So it'd be interesting to know your experience with New Yorkers in collecting 24-hour urine samples, which you apparently instituted with some success.
Sure. This was exciting because it was the first time it had really been done in sort of an urban setting and in a way that wasn't clinic-based. So often 24-hour urine collection is begun in a clinic and then people continue it at home. But we were actually mailing the collection kits to people in their own homes, which was an unusual protocol and required a lot of kind of supporting materials and development to make sure that people could follow the protocol at home. And then a technician came to their home at the end to take the weight, height, and blood pressure measurements. And we're really pleased that we had a great response rate. We feel like people followed the protocol well based on our ability to look at the volume and the time for collection. And we think it shows that it really can be done in other settings.
Good, thank you. Other questions?
Question from Envision.
Please.
Question for Christine Johnson. I wondered if you had estimated what level of impact your intervention may be expected to have, and whether you'll anticipate being able to detect that either from the survey that you described or from broader population measures such as trends in cardiovascular disease.
Sure. So it's kind of two pieces. One is when we think about our overall goal of that 20% reduction in population sodium intake, we're really working at the national level, so it would be a national level impact. And we haven't modeled it specifically, but we refer often to the Bibbins-Domingo paper from last year that looked at reductions of 1, 2, and 3 grams of salt per day and what the impact would be in terms of lives saved and also healthcare cost savings. And that 20% reduction in sodium is about a 1.7 gram reduction in terms of salt. So you can kind of use that to get an idea of what the impact might be at a national level. In terms of at the New York City level, we did look at sort of a percentage change that we would be able to detect over 4 or 5 years, and we based that on a change seen in the UK. And as I mentioned in my presentation, the UK had a salt reduction campaign that's been in place for about the last 5 years. We modeled it after them, and one of the things we were really impressed by was that they collected 24-hour urine, and they'd seen a decrease. And so we looked at the decrease they saw, which was about 4%, and looked at that as a potential effect that we might see.
Thank you. Molly, did you want to add something about monitoring and surveillance to assess the impact of future interventions?
Sure. So at CDC, some of the efforts that we're carrying forth include adding biological markers to the National Health and Nutrition Examination Survey, as Dr. Labarth had indicated earlier. But we're also looking at the possibility of using spot urines from either previous NHANES or going forward to measure sodium or changes in sodium over time, just because these measures don't rely on self-report.
Thank you.
So I have two questions. One of them has to do with any chance that we might see some of the major convenience stores on that list of volunteers. I quickly scanned the list and I didn't see Burger King, McDonald's, or others. I wonder what the chances are of getting. Is that salt is an important vehicle for fortification for iodine, and I'm wondering what our strategies are to maintain iodine fortification as we try to move away from salt. Is encouraging the industry to use iodized salt one opportunity?
Molly?
Okay, so I'll do my best to answer the iodized salt issue. In terms of changes in the iodine status of the U.S. population, in some subgroups, for example, pregnant women, they're on the low end at this point in time. In processed foods, food manufacturers do not use iodized salt. So if we're reducing the amount of sodium and salt used in processed foods, we're not going to affect the iodine intake. On a global basis, there are efforts. We recently had a meeting with the Pan American Health Organization to talk about global efforts when we're reducing salt in either processed foods or salt added at the table, that we need to increase the iodization of salt. So I think in the U.S., it's not so much of an issue, but globally, it really is an issue and is something that we have to think about, and efforts will be made in that direction.
I might just add on this point, for those who want to pursue this further, the World Health Organization website provides reports of two consultations, one in late 2006, published in April of 2007, and a subsequent one in May of 2007 that was published later that year. The first of those was a reiteration of WHO's longstanding recommendation that countries should adopt policies seeking consumption of salt less than 5 grams per day or lower if that policy was already in place. But they gave attention to the iodine issue. The second meeting was specifically to bring experts together from both the cardiovascular side and the iodine deficiency diseases side to try to reconcile their policies. The iodization policy requires consumption of 10 grams of salt containing iodine in order to meet the daily iodine requirement, where that is part of the public health strategy. Clearly, that in addition to whatever salt is contained in processed and restaurant foods, represents a policy collision. Detailed discussion and substantiated by documents in the report make clear that this is not an unavoidable conflict, that it is possible to increase the saturation of iodine in salt to achieve the target intake of iodine within a 5-gram salt intake. But it does require universal salt iodization, which is use of iodized salt in the preparation of manufactured foods. To your first question, major providers of food, you may or may not have seen about 2 weeks ago an announcement by Walmart that they would be seeking a major reduction in the sodium content of their products. And they are, by all accounts, the largest food retailer in the United States, accounting for about 20% of all retail food sales. So there's a big one making a very important promise of change.
And more recently, Subway also announced reductions in their products, which are still quite high, but.
Other questions or comments? Yes.
Christine, we very much appreciate you making the New York initiative a national initiative so the entire country can benefit from this work. A number of the companies on your list, and a growing list, I presume, are international in scope. Is there any discussion at all of other parts of the world benefiting from the progress that you're making? And I presume the progress you are making is a commitment to national change, so it's not a different set of Cheerios being distributed in LA versus New York, but I mean, it's sort of extending that. Is there any way to get commitments for other parts of the world? I presume Canada and others are interested in joining force.
Yes. So yes, all the commitments are for national changes, and that's why it's really so key that we have all these cities and states that have signed on, like California, New York State, Massachusetts, just to have all these states kind of represented at the table when we're talking to industry. They would not make yet changes for just one region. We definitely do stay in close touch with both the UK and Canada, and have discussed sodium reduction with Australia, because there are a lot of different initiatives on sodium reduction. That said, there's kind of two components. One is companies learn a lot about sodium reduction when they do it in one country, and sometimes that transfers. But all the companies have different product formulations for each country, and so it isn't, if they make a change in one product, crackers here, this exact same brand in Canada, they have to go through their own testing and own consumer approval process there. So there aren't targets that could really be across the board, but I think the more that we discuss and keep in touch, the more the categories can be aligned, and the more that we continue to kind of have the same process, so that it helps companies kind of focus their attention on the key categories to reduce sodium.
Thank you very much for your questions and for your attention. We'd just like to close with three messages. First, as pronounced by the Institute of Medicine in their 2010 report, the levels of sodium in the food supply of the United States today are simply not safe. We have heard that they are neither necessary, that a wide range of sodium content of the same food products points to the potential to reduce the sodium content of our food supply by a large degree. We'd add finally that it is not defensible. If public health is doing our job, improving the conditions in which people live, assuring the environment in which people can be healthy, we will be working together to reduce the sodium content of our food supply and help the U.S. population, as well as others around the world, to reduce their sodium intake. Thanks very much. Tanya?
Thank you all for coming. Let me just remind you that our next topic next month is Lyme disease, so we're moving a little bit back to infectious diseases. I would like you to give another round of applause to this really smart and gorgeous team.
Thank you.
See you next month. Thank you.